There's a really exciting live virus vaccine from the UK where AstraZeneca, the pharmaceutical company, is manufacturing the vaccine at scale while the trials go on. So if the trials are a success, they're going to have millions of doses ready to put into people's arms. So what we need to do is avoid mass death situations until we can get through to a point where we can effectively deal with this pandemic, which we will. But it's a matter of tenacity, and it's a matter of patience, and it's a matter of competence. And that's very patchy across the country. Some places have shown it, other places haven't. And I'm sad to tell you that I feel that my province at a provincial level is one of the places that hasn't shown that, although individual local public health units have really shone and distinguished themselves.
Thank you, Mr. Theriault. We go now to Mr. Davies. Mr. Davies, 2.5 minutes, please.
Thank you, Dr. Fisman. Last week, you stated, I continue to be concerned that there hasn't been enough attention given to epidemiology in kids. I know folks are starting to study that in Germany and Switzerland, but we haven't really studied it in North America. And then you said, for those of us who have been really concerned about the possibility that children may be important vectors of this disease. Given that we haven't done much research in North America and you're concerned that children may be important vectors, how do we square that with sending our kids back to school?
It's a dilemma. And honestly, I think I mentioned earlier, the signature of this disease is it takes off with big gatherings. So there's a lot that you can probably reopen economically safely if you stay away from large gatherings of people. The one big gathering that's really, really tough to cancel and which has huge economic implications is schools. That's the hardest thing. And the reason to be concerned about aggregating kids is that we see the evidence from other respiratory infectious diseases. Kids don't die of them, but they are tremendously good at transmitting these diseases.
So that being the case, why would we be sending kids who are vectors of this disease to gather in large gatherings to come back to homes where they may be in contact with seniors?
Yeah,
and I don't see what the dilemma is there. What's the dilemma?
I think that the idea is that economically it holds a country back. Even if we've got 40% of our workforce able to work from home, for the parents who are working from home, it's often difficult to get your job done if you're minding children in parallel. But yeah, it's an issue. Countries like Korea have kept their schools closed. Hong Kong continues to have their schools closed. I think they're just starting to reopen as they have approximately 0 cases at this point. But I think places with good public health leadership have done it very cautiously, because kids are the transmitters of infectious disease for many respiratory diseases, even if they themselves tend not to be sick by them.
Again, thank you as well, and thank you and for your work, your commitment, and your sacrifices too, along with all healthcare workers in Canada. Thank you all. Dr. Fisman, you talk about some of the best practices around the country, and I think it was Nova Scotia who you indicated they hunt the virus, and how Saskatchewan, they deal swiftly to contain in areas of outbreak. And then you talk about Alberta and how they've scaled up their testing and that they're the most potent and aggressive testing province in the country. And so I'm just at odds here. I don't understand how come Alberta can do it, but the rest of Canada cannot. Where are they getting their testing material? What's their secret in Alberta?
You know what? I'm not sure to what extent I can talk about private conversations in this public forum, but as I speak to colleagues across the country, what is clear to me is that the places that got the job done were aware of their deficiencies as laboratory systems and worked with commercial partners to automate processes in their labs. It's one thing to be testing 100 specimens a day. It's another to be testing 10,000 a day. And I think that the laboratories that are able to have high throughput here, and we do have folks, Mr. Ciceretto is probably the better one to answer this question. We do have folks in the country who know this stuff. You know, from the time the specimen arrives until the report goes out to the public health unit, not by fax, but electronically, that can be tremendously streamlined. So you don't get the bottlenecks that we've had in Ontario. I think a lot of the problems got blamed on supply chain, but clearly as supply chain has cleared up, it's still a rocky ride. I think in Ontario, there have been a lot of politics as well. I think you see that. We have had access to some testing data via the modeling process. You see that there's still this hugging going on where even as testing is supposed to get dispersed out to hospital labs and private labs, it's still getting hugged by the public health laboratory system. So I think in a time of national crisis, it's time to check your ego and work with whoever you can work with. It's actually the folks in Newfoundland. It was a remarkable experience to interact with them because, and perhaps this is a size thing, but it seemed a lot to me like an ego thing, where what you have is you have a provincial working group that has some former politicians, you have some leaders from health, you have leaders from business, and you have a couple of academics, and they're all at the table and they're all exchanging ideas. And it reminds me of the children's story Stone Soup, where everyone brings something and puts something in. You know, and at the end of that, they all have a good soup to enjoy together. That's how they do it in Newfoundland. And it was a revelation to me as someone coming from Ontario who's used to being asked for information that then goes off into a dark place, and you're never really sure who's seen it or who's used it or who's responded to it. It's just a very different way of doing business, and I think it served them well. They got the idea of hunting the virus from Iceland. You know, they looked over to the east and saw, well, you know, we've got Canada over to the west, and then we've got this other country over to the east, and the country to the east is doing a bang-up job. Let's talk to them. So, you know, I think being humble and looking for folks who are doing this better than you and learning from them is part of the magic.
Absolutely.
Thank you, Doctor. Thank you, Mr. Weber. We go now to Mr. Van Bynen. Mr. Van Bynen, go ahead, please. 5 minutes.
Thank you, Mr. Chair, and thank you, Dr. Fisman, for joining our committee today. It's so refreshing to hear such a wide variety of perspectives, and that certainly helps us in developing a good understanding of the situation that we're trying to find some solutions for. It's my understanding that you co-authored a study that examined the impact of enhanced contact tracing and restrictive physical distancing measures in comparison to a combination of enhanced contact tracing and less restrictive distancing measures. Could you please share with the committee the findings of your study and what the implications may have?
Of course. So I think what you're referring to is our paper that was in the CMAJ, the Canadian Medical Association Journal, in March. Our model looks a lot like most other models by competent modeling groups. It looks like the publication by a guy named Steve Kistler in Science that happened about a month after. What we projected was that reducing transmission through a variety of means can knock down the reproduction number of the disease and prevent your intensive care units from overflowing. Something we learned, which we didn't really anticipate, was that a lot of death in Ontario would come in the long-term care facilities. We knew that long-term care facilities were vulnerable, but had assumed as we were doing our modeling that people would actually try to protect them, which turned out not to be the case. So what we found is various combinations of case identification with contact tracing or just straight physical distancing are sufficient to knock the reproduction number down enough that your ICUs don't overflow, which has been the case in Canada, which is wonderful. So moving forward, we've now got a second iteration of that model in press in a journal called Annals of Internal Medicine, where we've been, thanks to the provincial modeling table, been able to calibrate the model. That means we fit the model to real data. We couldn't do that beforehand because we didn't have an epidemic yet to fit to. We can fit it to ICU occupancy in Ontario, and we can fit it to hospital death. The long-term care stuff is very challenging to try to fit into any sort of model. And what we see is that basically the lower we go in terms of disease activity and the slower we reopen, the longer it'll be before we have a resurgence. In our paper in March in Canadian Medical Association Journal, my colleague Dr. Chute Ashley Chute, who I've referenced previously, is a brilliant modeler, came up with the idea of dynamic social distancing, which again depends on really good public health surveillance. So you know when your hospital's starting to fill up again, and you know you have to strengthen your distancing measures. As I say, we think the group at Harvard who we're friends with may have copied that from us, and that came out in the Science paper as well a couple of weeks later. This idea, and a journalist referred to it as surfing the wave, that we're likely to go up and down and up and down and up and down with this disease for a while until we have a vaccine, which, as I say, it may come sooner than I ever would have imagined.
Thank you. Now, yesterday I asked Dr. Tam about the provinces and the territories and their plans to be reopening their economies, as well as people starting to leave their homes as the weather gets nicer. So as a follow-up, I'm wondering, with the information obtained from your study in mind, what are your thoughts on how this can be implemented safely?
Well, as I say, and this is not our work, there's a marvelous mathematician at Waterloo by the name of Chris Bouch, who's got a paper looking at regional reopening in Ontario as opposed to just blanket policies, with the outcome of interest being how can you minimize the amount of time in lockdown. And as I say, I think we're getting some organic reopening happening anyway as the weather gets better, and that's all right. This doesn't seem to be an infectious disease that spreads particularly well in parks, that spreads particularly well as people are out enjoying themselves, as long as they're maintaining a bit of distance. This really does continue to show that it's a disease that likes big crowds in indoor places. I think our most recent super spreader event here in Ontario is in a greenhouse workers in Chatham, which fits the description to a T, 50 people infected working in a greenhouse. So when folks are in small groups, have kind of low upper bounds on the number of people they're working with, call that work bubbles. When folks are enjoying themselves outside, staying fit, getting out into parks, enjoying outside with their kids, I think that's generating minimal risk for us. But what we do need is we need good, strong surveillance systems, and this circles back to our initial conversation about testing, that let us know when we're getting into danger again, as we were in March. I do think we're going to struggle in the fall, and we need, there's a lot of kind of hindsight at this point about, this thing emerged in January, but we didn't really get serious about it until March. I think we're going through that again. Anyone who looks at disease dynamics for a living can tell you we're in a lull now, probably going to be coming back in September, October. We've got some golden time now to get prepared for a likely resurgence in the fall. So I think we do need to build those surveillance systems and get much better at this by the time we get to the fall, because we're going to have to be more nimble then. Right. But I think there's much we can do. There's much we can do safely if we avoid large gatherings. The bubble idea is simply that, and a lot of corporations have at this point already instituted this. If you divide people up into relatively small teams, and you don't work simultaneously in the office, and you have a deep clean between teams being in the office, you've got an upper bound on how many people are going to get infected if someone comes into that bubble with infection. So I think there's a lot of ingenuity and there's a lot of wiggle room to reopen the economy safely, as long as we've got the surveillance systems that allow us to see when we're getting back into trouble.
Great, thank you.
As you know, Public Health Agency's opinion on non-medical masks. You also mentioned the mask adopt strategy. How can it's beneficial to the Canadian?
Well, we don't know, but we can be highly suspicious that it would help us a lot, especially if we can get the reproduction number of the disease down to around 1. That's a tipping point. So at that tipping point, very small changes in infection transmissibility can really make the epidemic fall through the floor and go away. What you have to remember about masks and a disease like this is masks work in both directions, right? They reduce the likelihood that you get infectious particles into your nose and mouth and eyes, potentially, if they keep your hands off your face, but they also prevent you from infecting other people. With this disease, that's probably the more important part, the reduction in transmission. And the reduction in transmission happens very efficiently, even with cloth masks. The reason that's so important with this particular disease is that what we know from work of Gabriel DeYoung and his colleagues in Hong Kong, which was published in Nature about a month ago, is that about 44% is their estimate in Hong Kong of transmissions occur in pre-symptomatic individuals. Those are people who are going to feel sick tomorrow, but they feel just fine today, so they haven't changed their behavior. So masks can be extremely impactful, because if I'm wearing a mask and I become infectious, but I don't know it yet, I don't infect you. And that's why